Hello, everyone. My name is Vijay Balasubramanian. I'm the founder and medical director of Valley Advanced Lung Diseases Institute, as well as the clinical professor of medicine at California Health Sciences University here in California, Fresno. So today's session is a clinical snippet on methamphetamine-associated pulmonary arterial hypertension. Methamphetamines are synthetic drugs that do not require the extraction of active constituents from plants that have to be cultivated and therefore can be made almost anywhere. They are highly addictive stimulants and are versatile for abuse. They can be smoked, snorted, injected intravenously, eaten, or even rubbed against the gums. They have many street names such as crank, ice, crystal, speed, tweak, and many, many more. Let's talk a little bit about the epidemiology. So why are we talking about methamphetamines? Methamphetamine use is increasing in popularity globally. They are the second most abused drug in the world, excluding cannabis. And methamphetamine represents the greatest global health threat. And this is according to the United Nations Office on Drugs and Crime report. Although methamphetamine use initially gained significant popularity in the United States, it is now a global drug and second only to marijuana in popularity. The World Drug Report 2021 highlights that in 2019, an estimated 27 million individuals worldwide, equivalent to 0.5% of the global population, reported using amphetamine-type stimulants. Substantial rise in all-cause mortality related to meth abuse has been reported in Australasia and North America. And according to the National Drug Database, methamphetamine is the top drug involved in overdose deaths in the western half of the United States compared to fentanyl in the eastern half. In 2020, nearly 2.5 million Americans, 12 and older, reported having used meth in the past year. The prevalence of meth misuse varies across the globe, and with North America exhibiting the highest rates of 2.3% and Africa reporting the lowest rates of 0.4%. In the United States, methamphetamine abuse varies by region, with higher rates in the western states compared to the east. It has been observed that male individuals tend to favor injection or snorting, whereas female individuals are more inclined towards smoking as their preferred method. Now, why are we talking about methamphetamines during the session? Methamphetamines are associated with significant cardiopulmonary and vascular toxic effects. Nationwide prevalence of adult methamphetamine-associated heart failure hospitalizations was estimated to be about 7.4 per thousand primary heart failure hospitalizations, according to one study. The potential association between methamphetamine exposure and pulmonary arterial hypertension first surfaced in 1993, a case report detailing severe pulmonary arterial hypertension in a truck driver with a 10-year history of methamphetamine use associated with propyl hexedrine inhalation. As time went by, in a retrospective study, it was discovered that patients with idiopathic PAH were 10 times more likely to have history of stimulant use, such as methamphetamine, cocaine, with methamphetamine being the most prevalent. Methamphetamine use was upgraded from likely to a definite risk factor for pulmonary arterial hypertension at the 2018 World Symposium on Pulmonary Hypertension. In the French registry, drug or toxin-induced pulmonary arterial hypertension accounted for approximately 9.5% of all cases. In the review registry, 10.5% of reported cases were found to have methamphetamine use. Overall prevalence is estimated to be about 9.77 of every 1,000 patients in one study. What about some of the United States-related data? The geographic distribution of methamphetamine-associated pulmonary arterial hypertension tends to track methamphetamine use, at least in the United States. Meth usage has increased exponentially at a rate of 17% per year if you look at the stats from 1999 to 2008, particularly in California. What are the characteristics of methamphetamine-associated pulmonary arterial hypertension? Very few studies have been done. However, lessons learned from these studies are patients with methamphetamine-associated PAH had a median duration of continuous methamphetamine exposure of 60 months, consistent across both sexes, 72 months for males and 60 months for females. The patients with methamphetamine PAH tended to be younger with a male predominance and predominantly non-Hispanic white. They exhibited less favorable right-sided hemodynamics compared with patients with the idiopathic PAH. The hemodynamic profile of methamphetamine PAH tended to be more concerning with higher pulmonary vascular resistance, lower cardiac output, and reduced stroke volume index. They also were less likely to be initiated on triple combination therapy or parenteral prostacyclin therapy in both the Stanford and PHA registry cohorts. Survival rates were worse in patients with methamphetamine-associated PAH compared with those with idiopathic PAH. Now let's look into the mechanisms of how this might happen. Methamphetamine is a dangerous psychomotor stimulant, exerts its effects by enhancing the signaling of catecholamines such as dopamine and norepinephrine. The heightened adrenergic activity is accompanied by neurotoxicity and neuroinflammation, leading to neuronal sodium. Although methamphetamine is distributed throughout the body, its uptake is highest in the lungs following IV administration. Vascular toxicity can be mediated via several mechanisms, including serotonin signaling, oxidative stress, and reduced activity of carboxylesterase, and dysregulation of the balance between pulmonary vasoconstrictors and vasodilators. With regards to management of methamphetamine-associated PAH, there are no individual phenotype-based studies to specifically treat this particular type. We just follow the guidelines as in any other group 1 pulmonary arterial hypertension patients. However, as mentioned before, these patients were less likely to be initiated on triple combination therapy or parenteral prostacyclin therapy. There are several challenges that are associated with the methamphetamine population. The main ones, obviously, are adherence, and adherence to therapy, adherence to follow-up. And there is also the other significant barrier, which is the lack of availability of resources such as de-addiction programs and psychiatric help and social support for these patients. In conclusion, methamphetamine abuse is a growing global trend. Prevalence is rapidly rising in the United States. Methamphetamine is associated with substantial cardiopulmonary and vascular toxic effects. Epidemiologic and longitudinal studies and registries are needed to understand this particular phenotype of pulmonary arterial hypertension. It is associated with significant morbidity and mortality. Thank you all for your attention. Please return to the Practice Point website to claim credit and view other related topics.